I think we are very fortunate that we are going to have this lecture by no other than Dr. Misra, who clarified so many doubts just now about the basic background tests that are to be done. This was, I think, clarified beyond any doubt. And we would request you now to please proceed your talk.
So thank you, Ashish.
Dr. Anoop Misra is the lead author of these guidelines. We are fortunate to have him.
Thank you, sir. Thank you, Ashish, for inviting me for this wonderful symposium. And I'm fortunate that my teacher, Dr. Vinod Kumar, is chairing this session, so I'm very fortunate. Just the background as far as this presentation is concerned, I'll just quickly run through a couple of slides and a couple of recent our publication. This is our editorial on adiposity as the core of tide of young youth onset type 2 diabetes. This is just published around a couple of days back, and you can see how the tide is going up and the obesity at the core, what we have been talking about. This is the most important thing at this point of time. And any of your patient comes, adiposity is something which is the core of so many diseases and must be targeted. Now, this is our upcoming publication in British Medical Journal, and overall gives an overview of type 2 diabetes in South Asians. It's not yet published, but accepted for publication. And you may not be able to see everything, but let me point out, among the factors which predispose to type 2 diabetes, two most important factors are, number one, increase in the body fat, and number two, the increase in the fat in the liver. This has been clearly initiated in this particular review. And we are seeing that this is our another publication in Metabolism, a high impact journal. And if you look at the disability adjusted life years, dailies, what are called, which is the impactful metric, ranking of India into 1990 to 2021. And if you look at the MASLD, we are almost in 2021, we are number one. And of course, diabetes, hypertension, obesity, we are number one or number two. So this is the kind of thing that we are seeing at this point of time. And before I begin the consensus guideline, you must know the new obesity guidelines. Now, I am part of both. This is the Lancet publication, and this is the publication for Indian population, which we put the revised definition of obesity for Indian population. And this goes something like this, that anybody above BMI of 23 should be considered obese. There is no overweight category now. And there are bifurcation into two, stage 1 and stage 2 obesity. Stage 1 has nothing else apart from high BMI. No abdominal adiposity, no diseases, or no adiposity induced symptoms like shortness of breath or any knee pain, etc. And while stage 2 adiposity has everything. So it has to have one measure of abdominal adiposity, which is high waist circumference or waist hip ratio, plus one of these two, obesity associated limitations in day-to-day activities, or one of the associated diseases. And look at the non-alcoholic fatty liver disease. At that time, we used the term NAFLD. So anybody with adiposity and NAFLD comes into stage 2, where aggressive therapies, we have been talking about lifestyle, we have been talking about drugs, all these are necessary. You throw everything at stage 2 of adiposity. And look at our data. This is quoted in our consensus guideline. This is liver fibrosis in patients with type 2 diabetes. I'm not talking about people who are normal, non-diabetic. This is type 2 diabetes. And 250, we published in 2021, only 39% did not have fibrosis, which means 60% had fibrosis already. Now, this is a damaging data, extremely concerning, because that's where we have to focus. And of course, gastroenterologists and hepatologists are already focusing. Severe fibrosis was seen in 18% of the cases. And the more the BMI, the more the fibrosis. You look at the categories of BMI, 25 to 30 and more than 30, and within the mild fibrosis, moderate and severe fibrosis with BMI. So BMI, body fat, most important determinant of liver fibrosis, but there are other determinants as well. So we looked at the guidelines. We looked at the guidelines. Countrywide guidelines, and Ashish was one of the most important person reviewing everything. We reviewed many papers over 6 months, lot of work. We reviewed Indian guidelines, we reviewed international guidelines. What we found out? Not a single guideline on type 2 diabetes. All non-diabetic individuals. So international guidelines, international gastroenterology and things like that, everything is just non-diabetic. This is the first guideline on diabetes published. But then we are not aiming at international audience. We are aiming only at Indian people. And that's where the problem lies. Problem is paucity of studies, paucity of research studies. So many times we are speaking like that. Well, we use this drug or we use that drug and things like that. We don't have data. Let's look at briefly, because I'm not going to talk about in detail, and those of you who want this, Ashish has the paper, we have the paper, Amrita is here, who's a part of these guidelines. She has the paper, and you can approach anybody. The body mass index has to be done in the workup of any diabetic patient. You should, every diabetic patient which is coming to you should have two metrics. One, BMI more than 23, and waist hip ratio, waist height ratio or waist circumference. Now there are limits to waist circumference and waist height ratio, which you can look up, or you can ask Ashish or Amrita, and we will provide you all the details. Physical examination, extremely important to notice acanthosis nigricans. And what I am seeing is many patients have been referred to me from various other hospitals, or 10 more people have seen, all have, none of them have actually mentioned acanthosis nigricans, while the patient has severe acanthosis nigricans. Most important clinical examination. And then of course abdominal examination and biochemical parameters, transaminases and things like that. And this simple test, which we should do in every patient. It's a ratio, proportion of age, AST level, platelet count and ALT level, and these are the limits, and I had a lot of help from Ashish on this, less than 1.3, 1.3 to 2.6 and more than 2.6 or 2.67, indicative of different stages. Now look at this, acanthosis nigricans here. And this is our paper, this is the only paper in the world. Simple clinical parameter. We looked at the liver fibrosis, and this predicts liver fibrosis like anything, 80-90% of the cases. So please note down this particular sign in every patient. Now what was the consensus? All patients of type 2 diabetes should be screened for MASLD. So while you are screening for other complications, please screen for MASLD. Clinical evaluation, I have already told you, look for acanthosis nigricans, look for metabolic syndrome, and of course there are a couple of markers where the more intensive evaluation is necessary. So this is the algorithm. This is the algorithm for assessment and risk stratification. So metabolic syndrome, you know the definition. Obesity, we have told you. Acanthosis nigricans, a long-standing diabetes. These need your attention more. And then according to FIB4 and LSM, which Ashish has already told you something, high likelihood of cirrhosis or significant fibrosis, this you can categorize according to these two. If you don't have the elastography available to you, just low resource setting FIB4 is good enough. Management. Lifestyle management 5% weight loss is something which is desirable. 7% for resolution of MASH, 10% for potential reversal of fibrosis. Now, as you've seen, that many of the drugs are achieving that. Minimum of 150 to 300 minutes of moderate intensity aerobic activity and resistance exercises. Now, there is a huge section on diet, and I'm not going to cover that because of the paucity of time. But a couple of things. Green leafy vegetables are extremely important, and something like broccoli, if you can buy it, and whole grains. These are, the whole grains, and several of the millets, and coffee. Coffee was a controversial thing, because when we looked at the Delphi process of more than 100 people who participated in this particular consensus, then many of them were divided as far as coffee is concerned, but we had a clear evidence from the several trials that coffee is good for liver. And what is bad is high fructose food, fruit juices, processed sugar, non-nutritive sweeteners, and so on. And similarly, monounsaturated fat, omega-3 are good. So monounsaturated fat, avocado, nuts, almonds, walnuts, pistachios, and seeds, etc. Deep frying is bad. Ghee, coconut oil, palm oil, butter, all saturated fat oil will get deposited in the liver. So simple sugars and saturated fat is something which our livers will not be tolerant. Our livers are anyway bad, so will not be able to tolerate. Now, anti-hyperglycemic and other drugs in the management. 7% A1C is something which should be standard. GLP-1 receptor agonists are number one now. SGLT2 inhibitors, pioglitazone, and statins and ARB should be continued. Don't look at this like elevated SGOT-PT and say, oh, statins will cause hepatotoxicity. Don't do that. The statins will actually benefit it. And if you look at the algorithm here, then low-risk population, even low-risk population, you should use, apart from standard care, GLP-1, you should consider GLP-1 receptor analogs and SGLT2 inhibitors and pioglitazone. High risk, intensify it, and in advanced cirrhosis, we have not much of a data as far as use of these compounds are concerned. Now, there are a number of drugs which you have heard, but many of them are acting beautifully at liver. Semaglutide is acting, I'm not going to details because somebody has already covered that. The tirzepatide, and these are top level publications in New England Journal of Medicine. Tirzepatide and MASH with liver fibrosis, then resmetirom, excellent drug. Dapagliflozin, revival of dapagliflozin, I'll show you a couple of slides of our trial, and the lanifibranor, another pan-PPR agonist. Now, this is our dapagliflozin trial which Dr. Amrita Ghosh conducted, and we looked at the 3-month use of dapagliflozin in those people who were uncontrolled diabetes, and used MRI proton density fat fraction, which is a very accurate measurement of liver. And when we looked at the people, they lost weight, their waist circumference was less, their subcutaneous fat, skin fold was less, and actually their strength improved. Though they lost weight, their strength, hand grip strength improved. And if you look at the liver fat reduction from 15% to 10%, this was published in one of the top journals called Journal of Clinical Endocrinology and Metabolism, and pancreatic fat also improved. So dapagliflozin is something which is a forgotten drug actually here. It is important because the previous one publication I showed you is a recent publication of biopsy-proven people where dapagliflozin has been used and shown to improve the fibrosis. That was BMJ publication. So there is the potential benefit of pioglitazone, vitamin E, bariatric surgery, liraglutide, semaglutide, SGLT2 inhibitor. I have no idea about DPP4 inhibitor. There are some studies here. Obeticholic acid, yes, but it has not been approved. Saroglitazole, I'm personally not convinced. None of the other people were also convinced, so we put this thing that it needs more data, longer term data are needed clearly, and there is no biopsy proven data at this point which is convincing. Resmetirom, lenifibranor. Of course, these also need more data as far as type 2 diabetes, but whatever publications are there included patients with type 2 diabetes. There hardly any role of metformin, atorvastatin. UDCA is useless drug, PUFAs, and ARBs and pentoxifil. So this is my final slide. So practical, how do we practically use these drugs? What would be the algorithm for you to take away from here? High-grade fatty liver without fibrosis, non-diabetic individual, use vitamin E, GLP-1 receptor agonist if patient is obese, and if available, is it available now? Resmetirom?
Yeah, it's available.
So, type 2 diabetes, metformin as the baseline drug, you cannot take it away. Patient is non-lean, non-obese, and or obese, pioglitazone. And here, obese, judicious use of pioglitazone, GLP-1 receptor analogs, and SGLT2 inhibitors, and resmetirom. So if you remember this, we'll be fine. Use judiciously, individualize the therapy, and patient will benefit from all angles. Remember, amongst these drugs, 2 are not diabetic drugs, vitamin E and resmetirom. Rest are acting on rest of the parameters as well. So thank you, Ashish, for giving me this opportunity.
Thank you, sir, for that wonderful presentation.
Thank you, Dr. Misra. As usual, you were excellent. And I think he has synthesized everything into a short presentation. He gave a reference of his paper, which is the only paper as far as the diabetics are concerned, for the consensus. You can read that paper. That paper gives all the details. I have read that paper. And I have one query from you, Dr. Misra. One of your earlier slides showed that for stage 1 obesity, only lifestyle management. If I tell you an example, suppose there is a person who has a BMI of say 28, who has a risk of cardiometabolic disease, say by, for example, by a positive family history, would you still manage lifestyle, or you would then especially think of pharmacotherapy?
Sir, entirely individualized. And there are a couple of situations where we can shift stage 1 to stage 2. Those who are gaining weight, those who are resistant to lifestyle management, and who are gradually developing symptoms related to weight, etc., those are actually converting from stage 1 to stage 2, and you should aggressively manage them.
And the second thing, you emphasize greatly on acanthosis nigricans. I think acanthosis nigricans is known for a long time in type 2 diabetes, particularly younger type 2 diabetes. And if I recollect properly, it is a sign of insulin resistance. And that must be true as far as MASLD is also concerned.
Sir, your observation is always pertinent. It has been known for a long time to be associated with insulin resistant. It is more often seen in Indian population who's anyway more insulin resistant. But this is the first time we've shown the clear correlation with the liver. We are working more on acanthosis. We feel that whatever research we are doing should benefit the physicians. It should not be esoteric research which is relegated to some paper and which is of no use to people. So all of our research now is currently practical research which you can apply to your patients.
One question.
Sir, a short query. In fact, we all talk of a easy thing, like we talk of pharmacotherapy, but the core of managing all these metabolic diseases, diabetes and MASLD, is lifestyle measurement. So how do you motivate your patients to stick to this lifestyle measures? Because whenever the patient comes for follow-up, the weight remains the same, the eating habits remains the same. Yeah, we are trying, we are doing it. I'm unable to motivate them, sir.
I think this is the most difficult thing to do. And there was one question from somewhere that people say, I can't exercise, I can't diet, you give me a drug. So this is the increasing situation that we are also seeing in the. But some people do very well. You just have to explain to them, give them time. The problem is that our busy clinic, we don't give them time to the patient. We should give them time, explain that this is the most important thing. And in our guidelines, diet has actually occupied the most space, more than drugs. And we have detailed the diet, because that is very important for MASLD. So the one thing is patient does not follow, because either he does not understand, you have not counseled him enough, or he doesn't want it. If he doesn't want it, repeatedly counseling will not help in many people, so we can't do much. But we must do everything to make him understand what are the benefits. Number two is the patient does it for a while, leaves it, and there are so many factors: depression, mental state, family deaths, and so on. We just put them back on the so-called treadmill. Well, okay, whatever you have done, not bad. We start again, and then they start again. And third is a person who's a chronic defaulter, gives you some reason or the other, which actually does not exist. Again, very difficult to handle such people.
Sir, one query. I must compliment you on the excellent and simplistic presentation, but classifying a person as obese more than 23 BMI, wouldn't it be putting almost every Indian, 80-90% Indian in that obesity category? Could we have a window of borderline overweight, 23 to 25?
There is nothing called overweight, sir. It really doesn't serve any purpose. Only it is a purpose that we have one guideline above which we again, practically, what we should do. Overweight, what does it mean? Obesity, bifurcated into two, we have rational application of therapy. Clear where we should apply our resources. Your resources may be limited, government's resources may be limited. So we watch where we should apply is clearly initiated in this. Now, the second thing is that 80 to 90% of the people, that is true, sir. That is true. The National Health and Family Welfare Survey shows that if you take our definition, which we established in 2009, as far as waist circumference is concerned, 80% of the women in the urban areas are abdominally obese, and around 40 to 50% if we take the BMI criteria. So this is something above which we have not made a criteria just because I was thinking something 23 is a good number. Nothing like that. We researched, when I was in All India Institute of Medical Sciences, Professor Vinod Kumar was teaching us. At that time, we did a lot of studies with Naval Vikram, who is now professor at AIIMS, and found that the moment person has a 22.5 or 23 BMI, all the comorbidities are increasing. So when we should act somewhere, we should act at 23. We should not act at 25, and it has already been set.
Thank you very much. We come to the end.
Yeah.
Grateful, thanks.
Thank you, sir.